Thank you for the invitation to present to you about the recent updates with Cortisol therapy in lymphoma. My name is Sattva Neelapu. I am from the Department of Lymphoma and Myeloma at the University of Texas MD Anderson Cancer Center in Houston, Texas, in the US. Here are my disclosures. So today I'd like to talk to you about recent updates with cortisol therapy from the pivotal trials in large B-cell lymphoma, mantle cell lymphoma, and indolent non-Hodgkin lymphoma. And I'll finish up with some novel mechanisms of resistance that have been described with cortisol therapy recently. So to begin with, I'll talk about the pivotal trial results from the Zuma 1, Juliet, and Transcend in large B-cell lymphoma, and also describe to you some recent results from the Zuma 12 study where cortisol therapy was evaluated in frontline large B-cell lymphoma. So this slide shows you the three different CD19 cortisol products that have been evaluated in pivotal trials in non-Hodgkin lymphoma. There are some similarities as well as differences across these three products. All three products target CD19 and in fact use the same CD19 antibody clone called FMC63. All of them have CD3 zeta to provide signal 1 for activation of the T cells, but the signal 2 differs with the axicell product using CD28 co-stimulated domain, whereas the other two are using 4-1BB co-stimulated domain. In addition, the lysocell product differs from the axicell and tisocell in that the ratio of the CD4 to CD8 CAR T cells is fixed at 1:1. This slide shows you the results from the Zuma 1 study where axicell was evaluated in relapsed refractory large B-cell lymphoma after 2 or more lines of therapy. The best overall response rate and the CR rates were 83% and 58% on this study. And at a median follow-up of 27 months, 39% of the patients remain progression-free. What's also nice to see here is this plateauing of this PFS curve at around the 6-month time point with very few relapses beyond that, suggesting that this therapy may be potentially be curative for these patients. At the recent ASH meeting, the 4-year survival update was presented, and we found that 44% of the patients are still alive at 4 years. And as compared to the historical data with the SCHOLAR-1 study, where outcomes in patients with relapsed or refractory large B-cell lymphoma were looked at in the pre-CAR T therapy era, we find that the overall survival at 2 years was improved from 12% to 50% with CAR T-cell therapy, suggesting that this therapy represents a major advance for the management of these patients. Similarly, in the other two pivotal trials, the Juliet evaluating tisocell product and the Transcend evaluating lysocell product, you can again see a plateau in the PFS curve at around the 35 to 40% range. In addition, the Transcend study also looked at PFS by different histological subtypes of large B-cell lymphoma. And what you can see here is that the patients with primary mediastinal B-cell lymphoma and transformed follicular lymphoma appear to have a slightly better PFS compared to patients with DLBCL NOS or high-grade B-cell lymphoma, as well as other transformed indolent non-Hodgkin lymphoma, such as transformed marginal zone lymphoma. In terms of toxicities, there are two common acute toxicities that are observed with CAR T-cell therapy. One is cytokine release syndrome or CRS. And you can see here on the Zuma 1 study, the majority of the patients develop CRS. However, most of these were grade 1 and grade 2, with 11% of the patients having grade 3 or higher CRS. On the Juliet and the Transcend, 22% and 2% of the patients had grade 3 or higher CRS. But it's also important to note that the grading system that was used to grade the CRS were different across these three trials. The Juliet using the UPenn grading system as compared to the other two trials which use the Lee criteria. And the UPenn grading system can upgrade the CRS related to the Lee criteria. In addition, neurological toxicity was observed in about two-thirds of the patients on the Zuma 1 study. Again, most of these were grade 1 and grade 2, with about a third of the patients having grade 3 or higher neurological toxicity. And on the Juliet and the Transcend, 12% and 10% had neurological toxicity of grade 3 or higher. And to manage these toxicities, these patients received either tocilizumab or corticosteroids. And you can see the percentage of patients who received these interventions on these three trials here. So these three pivotal trials showed that CD19 CAR T-cell therapy in large B-cell lymphoma may be just the beginning of a paradigm shift on how we might treat lymphomas in the future. So currently patients with aggressive B-cell non-Hodgkin lymphoma, when they're initially diagnosed, they receive R-CHOP or R-CHOP-like chemotherapy, which is estimated to cure about 60% of these patients. When they relapse after frontline therapy, and if they have chemosensitive disease, they go on to receive autologous stem cell transplantation, which can cure an additional 5% of these patients. And when they relapse after second line chemotherapy, these patients can now receive CD19 CAR T cell therapy, which is estimated to cure an additional 15% of these patients. So altogether, about 80% of all newly diagnosed large B-cell lymphoma patients may be curable today with these three different modalities. So this therapy is now being evaluated in earlier lines of therapy. Head-to-head randomized trials with head-to-head comparison of CD19 CAR T-cell therapy versus autologous stem cell transplantation are ongoing in the second line setting. And recently, CD19 CAR T-cell therapy was also evaluated in high-risk aggressive B-cell non-Hodgkin lymphoma in the frontline setting. So this study is the Zuma 12 study, which is a multi-center phase 2 trial, which evaluated axi-cel as part of first-line therapy in these patients with high-risk large B-cell lymphoma. The interim analysis from this study was presented at the recent ASH meeting. And to be eligible for this study, the patients had to have high-grade B-cell lymphoma with either double hit or triple hit, or large B-cell lymphoma with IPI score of 3 or greater. In addition, the patients had to have a dynamic risk assessment and had to have a positive interim PET scan with a dual score of 4 or 5 after at least 2 cycles of standard chemoimmunotherapy such as R-CHOP or R-EPOCH. So following enrollment and leukapheresis, they could receive optional non-chemotherapy bridging therapy while the product is being manufactured. And once the product was manufactured, they received the conditioning chemotherapy with cyclophosphamide and fludarabine on days -5, 4, and 3, and followed by a single infusion of axi-cel at a dose of 2 million CAR-positive cells on day 0. The primary endpoint for the study was complete response rate. Here are the baseline characteristics. At the time of the interim analysis, 32 patients were enrolled and treated. The median age was 61, with the oldest patient being 86. 41% of the patients were 65 years or older. Most of these patients had stage 3 or 4 disease, and about half of the patients had double hit or triple hit lymphoma, and about 70% of the patients had IPS score of 3 or higher. Half the patients had a dual score of 4, and another half had dual score of 5 on interim PET scan. The best overall response rate at this interim analysis was 85%, and the complete response rate was 74%. The median follow-up was about 9 months, and about 70% of the responses are ongoing at the time of the data cutoff. The median time to response was 1 month. About 19% of the patients had PR or stable disease at the 1 month time point, but about a significant proportion of these patients converted to a CR subsequently. When we analyzed the CAR T-cell product from the Zuma 12 study and compared it with the Zuma 1 study, where the CAR T was evaluated after 2 or more lines of therapy, we find that there was a higher frequency of these CCR7 positive, CD45RA positive, CAR positive T cells in the CAR T products in the Zuma 12 compared to the Zuma 1. And this associated with a greater CAR T cell expansion in the Zuma 12 versus Zuma 1, and that may account for the higher complete response rate observed on this trial to date. So the primary analysis from this trial are expected to be presented sometime later this year, and based on that, randomized trials are being considered. Moving on to the second part of my talk, I'll discuss two trials results found on CAR T-cell therapy in mantle cell lymphoma, the Zuma 2 study and the Transcend MCL study. The Zuma 2 evaluated KTEX19 in patients with relapsed or refractory mantle cell lymphoma. KTEX19 is very similar to the XSL product, except that there's a single difference in the manufacturing step where the T cells are enriched from the apheresis product before being transduced with the CAR construct. So to be eligible for this trial, the patients had to have relapsed or refractory mantle cell lymphoma after 1 to 5 prior lines of therapy, and following enrollment and leukapheresis, they could receive optional bridging therapy with either corticosteroids or BTK inhibitors, including ibrutinib or acalabrutinib. And once the product was generated, they receive again the standard Cy/Flu conditioning chemotherapy, followed by the single infusion of CAR T cells at a dose of 2 million CAR positive cells per kilogram body weight. And the first tumor assessment was done at day 28. The primary endpoint for the study was overall response rate. So this trial was previously published about a year ago in the New England Journal of Medicine and was updated with longer follow-up at the recent ASH meeting. And so out of the 60 patients included in the primary analysis, the best overall response rate was 92% and the complete response rate was 67%. At the updated ASH, with a median follow-up of almost 18 months, 48% of the patients had ongoing remission. So based on these results, brexacaptagene autoleucel or Brexocel was approved for relapsed or refractory mantle cell lymphoma in July of last year in the US. Here are the Kepler-Meyer curves. The median duration of response, the PFS and OS were not reached after a median follow-up of about 18 months. And 48% of the responses are ongoing as of the data cutoff, and 70% of the patients who achieved a CR remain in complete remission. And the ongoing response rate was consistent across various adverse prognostic groups, including older patients, as well as different morphological subtypes of mantle cell lymphoma, the Ki67 status, the disease stage, the MIPI score, as well as the P53 mutation status. There was also another study presented at the recent ASH meeting. This is looking at CAR T-cell therapy in mantle cell lymphoma. So this is a cohort of patients with mantle cell lymphoma who were treated on the Transcend NHL-001 study. And to be eligible for this study, the patients had to have at least 2 or more lines of therapy, and prior BTK inhibitor, alkylating agent, as well as anti-CD20 agent are allowed. And following leukapheresis, they could receive bridging therapy, but had to have PET positive disease confirmed prior to lymphodepletion with Cy/Flu, followed by a single infusion of lysocell. This trial started as a phase 1 study, so there were 6 patients treated at the dose level 1 with 50 million CAR positive cells. And for the pivotal portion of the trial, 26 patients were treated at the time of this interim analysis with 100 million CAR positive cells. Here are the baseline characteristics. The median age was 67, with the oldest patient being 80. About 72% of the patients had Ki67 of 30% or higher. 40% of the patients had blastoid morphology. 22% of the patients had TP53 mutation. 88% of the patients have been exposed to prior BTK inhibitor, and 25% to venetoclax. About 34% of the patients had prior stem cell transplant. So at the time of this interim analysis with 32 patients, the overall response rate was 84% and the CR rate was 66%. And these responses were seen consistently across various prognostic groups, including the Ki67, the blastoid morphology, as well as patients with P53 mutation. And here are the swimmers plot. The follow-up is still short with a median follow-up of 3.9 months, but you can see there are a few patients who are beyond the 1-year time point with ongoing remission. So moving on to the third part of my talk, I will discuss 2 studies where CAR T-cell therapy was evaluated in indolent non-Hodgkin lymphoma, the Zuma 5 study and the ELARA trial. The Zuma 5 study evaluated axi-cel in this phase 2 multicenter single-arm study in relapsed or refractory indolent non-Hodgkin lymphoma that included patients with follicular lymphoma as well as marginal zone lymphoma. And they had to have 2 or more prior lines of therapy to be eligible for the trial. There were a total of 151 patients enrolled on the trial, and 146 patients were treated at the time of this primary analysis presented at the ASH meeting by Dr. Jacobson. The conditioning regimen was similar to large B-cell lymphoma with Cy/Flu followed by a single dose of axi-cel, and the primary endpoint was overall response rate. Here are the baseline characteristics. If you look at the column to the right, for all patients, the median age was 61, with the oldest patient being 79. A third of the patients were 65 years or older. 86% of the patients had stage 3 or 4 disease. About half the patients had high-risk FLIPI. About half the patients met GELF criteria. 64% of the patients had 3 or more prior lines of therapy. And about half the patients fell into the POD24 risk group, and a quarter of the patients had prior auto transplant. Overall, out of the 146, 124 patients had follicular lymphoma, and 22 had marginal zone lymphoma. Taking all patients into account at the time of the primary analysis, the overall response rate was 92% and the complete response rate was 76%. But if you look at the 2 different histologies, follicular lymphoma and marginal zone lymphoma, you can see that the CR rate was higher in follicular lymphoma at 80% versus 60% in marginal zone lymphoma. And the median time to response was 1 month. About 25 patients who initially had a PR at the 1 month time point, about half of them subsequently converted to a CR. And these responses were consistent across the key prognostic subgroups, including the FLIPI score, the POD24, prior auto transplant, and number of prior therapies. The median follow-up at the time of this presentation was about 18 months, but the median PFS and OS have not been reached to date. And the 12-month PFS rate was about 74%, and the 12-month overall survival rate was 93%. The therapy was quite well tolerated in this patient population, with only 7% of the patients having grade 3 or higher CRS, and 19% having grade 3 or higher neurological events, which is lower than what was observed on DLBCL and MCL studies. The ELARA trial evaluated tisagenlecleucel in patients in a large multicenter phase 2 single-arm study in relapsed refractory follicular lymphoma. And to be eligible, they had to have follicular lymphoma of grade 1, 2, or 3A, and relapsed after 2 or more lines of prior therapy. And once the patients underwent leukapheresis, they could receive optional bridging therapy and received a single infusion of tisagenlecleucel following conditioning with either Cy/Flu or bendamustine. And the dose of tisagenlecleucel varied from 0.6 million to up to 60 million to 600 million CAR-positive cells. And the primary endpoint was complete response rate. So the interim analysis from this ELARA trial was presented at the recent ASH meeting with 97 patients enrolled. The median age was 57, oldest patient being 73. The median number of prior therapies was 4, so this was a heavily pretreated patient population. 60% of the patients had POD24, and 77% of the patients were refractory to last line of therapy. The study met its primary endpoint for complete response rate at the time of the interim analysis, with 52 patients being evaluable. The CR rate was 65%, and the overall response rate was 82%. And again, these responses were consistent across various key subgroups. And on the right, you can see the median, that the median duration of response has not been reached. The therapy was quite well tolerated, with no grade 3 or higher CRS observed, and only 1% of the patients had grade 3 or higher neurological toxicity. The median follow-up is short at about 10 months, but the median PFS and OS have so far not been reached, and the 6-month PFS rate is 73%. So I'm going to finish up with with novel mechanisms of resistance to cortisol therapy that have been recently been described. So previously, it's been observed that after axi-cell therapy in diffuse large B-cell lymphoma, approximately a third of the patients can relapse with CD19 loss tumors. And this CD19 loss could be either due to alternative splicing or mutation or loss of heterozygosity. About two-thirds of the patients who relapse with CD19 positive disease. And there are two recent reports highlight some novel mechanisms of resistance in these patients. One report from our group published in last month in Nature Medicine, where we performed single-cell RNA-seq on the CAR T-cell products and found that the characteristics of the CAR T-cells seem to associate with both efficacy and toxicity. And another recent report from the Stanford group presented at the ASH meeting in December 2020, they showed that alteration in CD58 seems to be associated with poor outcome after axi-cell in large B-cell lymphoma. So here's the first study from the Nature Medicine where we performed single-cell RNA-seq on CAR T-cell products, and we found that the functional state of the CD4 and CD8 T cells seem to associate with the clinical response in relapsed refractory large B-cell lymphoma. We found that patients who had higher proportion of cycling CD4 T cells, meaning these are actively proliferating CD4 CAR T cells, associated with a higher CR rate at 65% compared to the lowest group, where the CR rate can be as low as 0%. We also found that the CD8 functional state of the CAR T cells also can be associated with clinical response with patients who had a higher proportion of memory CD8 T cells associated with superior response. You can see here as defined by the CCR7 expression and CD27 expression. Patients who had achieved a CR had 20% of the CAR T product of memory cells versus only 7% in those who did not achieve a CR. In this study, we also looked at molecular response status at day 7 and found that molecular response status at day 7 as determined by CAP-seq may associate with durability of response in these patients. If the patients had more than a 5-fold decrease in the molecular response in the variant allele frequency at day 7 after axi-cell infusion, then they have a 75% chance of for ongoing complete response rate 3 months. But if their molecular response status was less than 5-fold, then all of those patients relapsed by the 3-month time point. So consistent with that, we found that the patients who relapsed within the 3 months had a higher frequency of exhausted phenotype of CAR T cells, CD8 CAR T cells in their product, as determined by dual expression of LAG3 and TIM3. You can see the patients who had less than 5-fold molecular response, 37% of these CAR T cells were LAG3 and TIM3 positive versus 23% in the patients who had a better response. In the second mechanism that's been described by the Stanford group, presented by Robbie Mesner at ASH, where they showed that CD58 mutation or alteration in the tumor could be associated with poor outcome after axi-cell in diffuse large B-cell lymphoma. And you can see here the CR patients had CD58 wild type, then 80% of them achieved a CR versus only about 25% if there was CD58 was altered, meaning either decreased expression or loss of expression or due to a mutation in these patients. And if they had CD58 mutation, all of the patients relapsed by 6 months versus 40% of the patients who had wild type CD58 had ongoing remission long term. And they went on to analyze the mechanism of this in the preclinical models and found that CD58 provides a co-stimulatory signal to the CAR T cells. And if they mutate or knock out CD58 from a leukemia cell line, in this case NAM6, then the CAR T cells were not really very effective with all of the mice relapsing, versus if the CD58 was wild type, then they could achieve 100% survival, especially with the CD28 CAR. But they also found a way to overcome this mechanism of resistance by providing CD2 co-stimulation in the CAR T cells by expressing the CD2 co-stimulating molecule in trans, and found that in this mouse model, if they did that, then 100% of the mice achieved survival, versus if there was no CD2 co-stimulation, then all of the mice relapsed. So to summarize, autologous anti-CD19 CAR T-cell therapy has been shown to induce durable remissions in about 35 to 40% of patients with relapsed or refractory large B-cell lymphoma. There are currently at least two products that have been approved for large B-cell lymphoma, Axicell and Tisocell, after 2 or more lines of therapy. Lysocell is currently under regulatory review for the same patient population. Promising activity with Axicell has been shown in the Zuma 12 study in first-line high-risk large B-cell lymphoma, and phase 3 randomized trials comparing CAR T versus auto transplant are ongoing. The results are expected either later this year or next year. And promising activity has been demonstrated in pivotal trials in both mantle cell lymphoma and indolent non-Hodgkin lymphoma. And there's at least one approved product for relapsed or refractory mantle cell lymphoma, Brexocell, after 1 or more lines of therapy. And the primary analysis for Axicell in indolent non-Hodgkin lymphoma was recently completed and under regulatory review. The CAR T cell functionality in the product appears to associate with clinical outcome, with the memory phenotype favoring good outcome versus an exhausted phenotype being associated with early relapse. And similarly, CD58 mutation or alteration in the tumor appears to be associating with poor outcome after CAR T cell therapy in large B cell lymphoma. So with that, I'd like to stop and thank you for your attention.